Today we welcome back Dr. Kathy Dooley. Today we talked about something everyone can relate to, from low back pain to sciatica. But do we really understand it? Dr. Dooley will take us on a deep dive of anatomy and explain away a few myths and thrown around terms. Sit back and let's have some fun with this amazing doctor who is a professor at 4 medical schools on this episode of the Crackin Backs.
Alrighty, here we go. Part 2, Spencer.
Well, I'll tell you, Kathy, you were so well received, and it was that we definitely wanted you back, as you know.
Great.
More interesting is that in the last 1 week, it was very serendipitous. Nobody knew that I was going to have you back on, but 2 of your biggest fans, Dr. Ann Sorrentino, you may not know. I think you know.
I do.
She said, she just came out of nowhere and said, "You got Kathy Dooley coming on again? You know, she's wickedly smart, and you would never expect all that conversation to come out of her mouth."
You know how, Spencer, they never said that about us, that we're wickedly smart. It's always the guests that are wickedly smart.
No, God, I usually get, "Wow, that was a stupid comment you made." No,
No, you're both wickedly smart. Of course you are.
And then your second biggest fan, who actually, and this is such a perfect time to have you back on, is Dr. Karen Slota. Just told me that you are doing a 6-hour program tomorrow.
Yeah,
on
5 to 6 hours. Yep.
On sciatic pain.
Sciatica. Yep.
I couldn't believe it. So, with that said, welcome back.
Thank you.
And I want to ask the anatomy angel a couple questions here.
Okay, I'm ready.
People. Let's start out with probably one of the most common problems that Americans are experiencing, and that's low back pain. Low back pain. They typically come into our office and say, "I have sciatic," and yet, they don't really know. They just know it's pain in the ass. And I usually tell them, "We'll get a divorce and you'll be fine." No, they say pain down the leg and all that. Can you just elaborate on some of the teasers that you may be sharing tomorrow and what you can say to the general public?
Absolutely. Well, of course, as a chiropractor and as a rehab specialist, I treat quite a bit of pains in the gluteal region. What people call sciatica is so fascinating to me. They'll come to my office saying they have sciatica, and then they'll point to the front of their thigh. And I'm like, well, no. But then I don't think that they know how to differentiate, sciatica, which is usually just referral from the ischiatic region of the buttock down the leg. They don't know how to differentiate radiculopathy, the impingement of a single nerve root, usually caused by a space-occupying lesion, and an actual pain that's deep gluteal syndrome, what most people call, it used to be called piriformis syndrome. And they changed the name of that because it's not a great name for anatomical reasons. The thing that's so fascinating is that a lot of people will go and they'll get imaging and they'll support their ideas with the disc herniation. But when I'll come to the office, I'll say, wait a minute, do we actually know that this nerve is impacted? Sometimes the signs and symptoms are actually on the opposite side of what they're reporting. So it gets really, really interesting to try to match some of the imaging studies to what they experience. So I try to walk them through the experience of what is it like for you? What does it create for you? And then putting them through, nerve entrapment tests, of course, like the slump test and sciatic nerve entrapment signs, and then find if they truly have certain symptoms and how they match their entrapment sites. And it gets really, really interesting when the patient's like, "Oh, I thought it was because of my disc pathology." And sometimes we find that it's actually due to something distal to that.
Could you mention something that people often come up with this? They went to their regular doctor, they got an MRI, and there's the reason, a disc herniation. Why is that not always the case?
Well, I think that structure and function, we always wanted them to match, and sometimes they don't always match. And that's why the physical examination must be completed. I get really upset for my patient if they told me that their doctor hasn't laid a hand on them It's really strange to
Right.
me that they would just use the imaging and not actually do provocation tests and look and see. And there's brilliant orthopedists that actually do that. They'll match the imaging, and I only tend to work with those orthopedists if I can, so that we can do a really great co-caring situation. I think that we get caught up so much on the fanciness of imaging, and there's even like a technical term for it called vomit, victims of medical imaging technology, where we try to I didn't make that up, I didn't coin that. It's if you Google it, it pops
That's
right up.
fantastic.
But the thing that's so interesting is that I'll tell my patients, look, you can have a disc pathology, but if you don't match by a neurological exam, if it doesn't match the disc pathology that you have, and you could have 3 or 4 herniated discs, so you could have impingements on several nerves and not actually present with provocation. And that's what's so fascinating, is that we have to get the structures that we see non-dynamically on an MRI or non-dynamically on a radiograph. We have to get that to match the dynamic physical assessment. And I don't want to see the neurological exam or the physical assessment exam die. And that's why I do the anatomy angel sciatica courses. That's why I try to keep a pulse on the neurological exam.
Is it possible? I mean, I know the answer, but I mean, I want the general listeners to know that you could have a disc herniation on imaging on an MRI and not have pain.
100%
It
possibility.
might be an old injury.
It's actually a probability. Discogenic problems, if you could actually have a disc pathology hitting a nerve root on an image and a person not have sciatica. I've seen that happen too, where, a person will come to me and they'll have, let's say, L5 radiculopathy, the L5 on the side. They'll feel like numbness on the side of their butt and into the side of their leg and into the front side of their leg into the top and bottom of their foot. So they'll have the L5 on the side stuff. They'll come in and their imaging will show, extravasation of disc contents hitting a nerve root on that side, hitting the L5 nerve root. And then they'll also have a disc pathology on the left side hitting the L4 nerve root, and they don't have any symptomatology. So it's not just a matter of the structure, but the systemic situation of the patient. If they have an inflammatory cascade or a neurological sensitization that's a little bit higher due to systemic reasons, due to, a number of pathological reasons, sequelae can present differently based upon the structural situation. So you have to match an imaging report. You can't marry it. I tell people, don't wear it like it's a badge of honor. Like, I have a disc pathology. Like, so what? 50% of all disc herniations resorb spontaneously within a year. It doesn't mean necessarily that you're a candidate for surgery. And it also doesn't mean that you won't respond to treatment. In fact, the odds are pretty good that you will. So let's not marry the image. Let's use it to our advantage as a tool to get us to the right situation of rehabilitation for you, and hopefully avoid, the slice and dice situations of surgery.
Have you seen them order? When I say them, I refer to generically medical, even some in our profession might order an MRI, say there's a disc herniation. You don't know if it's an old one versus a new one because they forgot to ask for contrast or gadolinium. Do you find that happening?
Oh, I think the majority of MRIs aren't done with contrast because they're more expensive, and you want the MRI without contrast to show clinical symptomatology, or to be matched with the clinical symptomatology first before they'll even run it with gadolinium and contrast. And it's a cost procedure. It's even hard for some of my patients to get approved for their MRI these days, because if they don't have radiculopathy, you might not be able to get it. It's very strange. Therefore, I think it is a challenge to get it, but I think that I want to advocate my patients to push for it. Also, though, I don't want them to get too married to it. It's a real slippery slope. Because once they see that they have a disc pathology hitting a nerve root, and they go to an orthopedic surgeon, and the orthopedic surgeon, of course, is going to suggest typically surgery in these situations, you have to tell them, and they'll give them the scare tactics of, if this goes on for 6 weeks more, you're going to get irreversible neurological damage. And I'm like, well, I've also seen you do a laminectomy or microdiscectomy, remove those contents, and they still have the nerve damage. So I don't like these empty promises placed on patients. And I don't like the fact that we don't encourage rehabilitation right out the gate And usually they'll say, okay, we'll do rehabilitation for 6 weeks. Okay, they may have been earning a disc herniation their entire life, but you get 6 weeks, on your back to help them, change their entire lifestyle and create a rehabilitative situation. 6 weeks, tick-tock. And if you don't have an improvement in your neurological situation, then we have to do surgery. It's just not enough time.
6 weeks. I had a patient yesterday that said his insurance gave him 5 visits. I'm like, and the guy was 70-something years old. I go, how are you supposed to fix a condition in a PT in 5 visits? They can't.
You can't, but you can. Sometimes people only give me 2 visits. They put a lot of pressure on me because I don't take insurance. I'm out of pocket, so they're like, okay, tick-tock, Dooley, you get 2, and okay, rock star, go ahead. And I'm like, okay, fine. I'll do what I can, and I'll try to influence. I'll try to educate. I really try to go the extra mile to do what I can in those 2 visits, and that might be all I get.
Yeah.
And but one of my patients, I adore. He really trusts me, and he had an orthopedic surgeon tell him, with his disc pathology, look, you've got, not foot drop, but you've got a neurological deficit in, your ability to stand on your toes. That's one neuropathy, right? So he said, okay, if we don't go in and do this discectomy, then you're going to have permanent nerve damage. And I'm like, well, that's not true. That's not necessarily true. I will support you in your decision if you decide to do surgery, but can we just see if we can, decrease your buttock discomfort, decrease your sciatic discomfort, and also maybe if we get a little bit more on your reflex test, a little bit more on your standing on your toes test, your neurological exam, can we delay the surgery? So he just kept delaying it. Every 6 weeks he would delay it, because every time he would do a follow-up with the orthopedic surgeon, he had a better neurological test. So that's the pressure I like on me, that, he does his corrective strategies. I never met this person in person. It was only telehealth. And so I just had to do a neurological exam a tricky way. And he, of course, avoided the surgery, has, full plantar flexion back, but it took us 6 months. Would
you recite? Mm-hmm. Oh, sorry. I was just go ahead.
No, go ahead.
No,
I was just saying, like I couldn't have done it in 6 visits. It took us longer.
Would you recite the reasons for someone to actually get surgery? Let's say low back. What would be the criteria?
I guess, severe foot drop with no improvement after a 6-week period of, I want to see something happen in 6 weeks. I want to see an improvement. If you have this massive disc blowout and severely impacting the nerve root, and you get this massive atrophy, a really expedited atrophy, right? I could certainly see doing a discectomy. I don't think laminectomy is appropriate anymore. I really can't see the argument for it when we can do microdiscectomy and spare the multifidus. I don't know, I've had some very frustrated patients that have had these major blowouts and had, laminectomy and they still have the neurological deficit, and they're like, why didn't it come back? I'm like, because there's no guarantee that it will. And if the impact is so significant, the hope is that it will. And, when you damage nerves enough, getting them to regenerate is challenging. I believe in neuroplasticity, and I believe in rehabilitation and forcing the neurons that still exist to demand and pick up the slack. Just like if your MVPs are knocked out, you put in the bench warmers and then get the bench warmers trained up, and hopefully they'll take over the team. But, space occupying lesions are usually the reason, and major disc blowouts can certainly do that. Tumors, obviously, are a great time to do surgery because you can't rehabilitate a tumor away. But
loss of bowel and bladder control.
It's caught Aquinas syndrome, sure. I mean, these are like medical emergencies. Mm-hmm. But your garden variety sciatica is not a medical emergency.
Well, we often hear the patient that comes in that doesn't want to get surgery go, oh, the surgeon just wants to clean it up. And it makes it sound so simple.
Yeah, and it's not. And the thing that's so, let's face it, as soon as you go under anesthesia, there's risk. Anesthesia is a risk. Okay, it's an underestimated risk. There's A. Okay, B is infection. Great place to catch an infection is a hospital. As clean and as sterile as the situation is, you can your life-threatening, viruses that, especially MRSA, for bacteria. Like they exist in a hospital because that's where the sick people are, and that's where bacterial resistance exists. Iatrogenic infections, nosocomial infections that certainly can be earned in a hospital. It's a great place to get them, and also you're cutting into stuff, even in an endoscopic procedure. The endoscopic procedures for microdiscectomy, I can get on board with. They're really trying to do very minimal damage to the multifidus. They're trying to not your microdiscectomies. They push the multifidus to the side, right? They cut out a little piece. They push everything to the side. The endoscopics, they're trying to do as little as possible, and I can get on board with it. I've had a couple of patients that have really gotten out of their nerve pain with an endoscopic microdiscectomy, but that's not what's done by the majority of physicians still. So until we can evolve the surgeries a bit, I'm going to encourage my patients to avoid them as much as they can.
Isn't there pain from just disc injury without anything banging up against the nerve roots? I mean,
sure. Those people actually have back pain. Yeah, they have back pain. People with disc herniations affecting the nerve root don't usually have back pain. They usually have neuropathy. They have sciatica, right? And they have burning butt pain. But the disc itself is innervated, so you can actually get discogenic pain without sciatica.
How about going back to piriformis syndrome, which...
Yeah.
If you could bring me current on why you don't like piriformis syndrome.
Because true piriformis syndrome would indicate that the sciatic nerve is split into its two major parts, the tibial nerve and the common fibular nerve, within the belly of the piriformis. And that exists in a very seldom, representation. I'm at 2,700 cadaver patients, which means I've seen 5,400 gluteal regions. And I'll tell you that I don't see that very often. And I certainly don't like us to term it piriformis syndrome when there's a lot of things that are in that sciatic notch area, that greater sciatic notch area. I think that piriformis can be one piece of it, but deep gluteal syndrome is a better name because the sciatic nerve can also be occluded or entrapped by the long head biceps femoris, which is also in the deep gluteal region. And so I see that in 100% of cadaver patients, the sciatic nerve goes underneath piriformis and also goes underneath the long head biceps femoris, which is why when you're doing a slump test or doing an active straight leg raise, people get neuropathy because the long head biceps is getting stretched at the butt and at the knee. And that's why people also bend the knee when they have sciatica because they're trying to decrease nerve tension load. So it's a better name, deep gluteal syndrome, than just blaming everything on poor piriformis. It's not fair.
Well, I would like to add that, 0.01% of the population that actually have piriformis syndrome, back in chiropractic college, we actually had a cadaver that had the bifurcating the sciatic nerve punching through the piriformis.
Yep.
And we were all like shocked. We're like, what is this? But I never heard about it.
Yeah, it's a high brancher. Like, honestly, I've seen it out of the 2,700. I've probably seen it maybe 50 times. It's not enough to blame everybody with sciatica, with piriformis syndrome. And I'm not saying that the piriformis, it can't be an occlusion site for, or, entrapment site for the sciatic nerve. Of course it can. But the deep gluteal description is better. So in my sciatica course, I teach people, hey, do these tests of external rotation and abduction to see if it elucidates the sciatica versus hip extension and flexion, which piriformis has nothing to do with. That would also be deep gluteal syndrome, but caused by the long head biceps femoris. So they're both deep gluteal syndrome, but the corrective strategy for them would be different, and that's knowing your anatomy, and that's why anatomy is so important in a clinical situation.
So for the lay listeners out there, I mean, some of the conversation may get too complex. So I'm going to bring it back to something that people can really relate. Most men can relate to. And that is, what is the opportunity to have sciatic pain based on stuffing your wallet in your back pocket?
That would be deep gluteal syndrome. So that could be piriformis or long head biceps. So what you're doing when you put a wallet in the back of you, whether some people put their phone back there, some people put their wallet back there. What is a problem is that you create a pelvic discrepancy and a possible entrapment site. I think that, consistently doing that certainly will not improve the situation. But then again, I see people in the gym foam rolling their butt as if it's their second job, and they don't seem to get sciatica. So I feel like, sure, like it could be part of your clinical auditing process to ask someone with sciatica, do you put things in your back pocket? Do you find the need to stretch your butt all the time? Do you, when you sit in a car, do you, feel like you have to wedge something underneath your butt to feel balanced? Like those are great clinical auditing questions.
Well, I had a patient some 25 years ago that I told him he needed a walletectomy. And he looked at me like, what? And I go, don't you find it odd that every time you sit in your car, you have sciatic pain on the side where that damn wallet is? It looks like a telephone book that you shove.
Kind of like the George Costanza wallet from Seinfeld, where he was shoving stuff in.
Yeah. Well, part of it is the big wallet, but there's a reason why he gets it in the car is because it's the seats in a car have excessive flexion. And so if somebody is tensing the sciatic nerve in a hip flexed position, in a lumbar spine flexed position, is certainly a way to get neuropathy to come out, particularly if you wear a big fat George Costanza wallet.
That's great. That's great. The other thing was you started to mention foam rolling, but I think it is absolutely fascinating how with the vibration gun, we know it as a Theragun, but there's so many different types out there that they will go ahead and pound on this inflamed nerve thinking that they're going to massage out the muscle.
Well, the thing I tell them is that, careful with that Theragun, because where you think that the piriformis is, right? It's piriformis and sciatic nerve and superior and inferior gluteal nerves. They're arteries, nerves, and veins. The pudendal nerve, artery, and vein. Let me tell you what, nerves don't love vibration, and they can get very easily irritated. And you don't just have one nerve here. You got 4 major nerves and then a couple of extras going to some external rotators. So the reason why people feel so much soreness at the sciatic area is because so many anatomical things are there. It's not because their piriformis is a problem, or it's not because necessarily their sciatic nerve is a problem. There's like an explosion of anatomy, like a fountain coming out of that upper mid butt cheek. And so I tell my patients, foam rolling something, if you find that it gives you relief, I certainly understand why you would go there, but you might want to understand why it's tight in the first place. Because I don't think people have a foam roller deficiency. I think that they get tight because their bodies are geniuses. Their bodies are geniuses. They get tight because they have to. It's like a parking brake on a car. You put the parking brake on as a safety mechanism, just in case, you roll down the hill. So I tell people assess the tightness, and don't just roll it away because you might be rolling something that is trying to protect you.
Again, for the lay public and even the doctors that are listening and how they can talk to their patients more congruently and in basic language. When there is nerve impingement and you feel the radiating pain, or you may not feel the radiating pain, can you share what some of the other signs and symptoms that are experienced right before the major sciatic pain or the major pain? Like what else can go on? As a like a precursor, as a pre-warning.
The sequelae are different for everyone, but the things that happen first and foremost is a loss of position sensing, a loss of proprioception. So what will happen is an area just feels a little different than another area. Like they'll start to feel a change in sensation. It isn't necessarily pain. Pain comes a little later. It's like the last guest to show at a dysfunction party. Right. So they'll have a change in that position sensing. And I usually describe it as like when someone's gently stepping on a hose as they're watering the garden, and the water's just not coming out as great as it should. So you look back and see, is there anything including the water pathway? And that's exactly what's happening to the patient. They're losing position sensing because it's much faster to the cerebral cortex than pain is. Motor function is actually lost much later because motor is a slave to proprioception. You have thousands and thousands of proprioceptors, but only a few places where the nerve actually innervates the muscle, supplies the muscles. So, and the way that we execute motor is a sensory dependent situation. We rely on our sensory system to tell us how to output. And so, way before atrophy happens or an actual loss of strength output, we lose position sensing, then we start to get numb and tingle, then we start to develop motor deficits. And that's typically that order.
Muscle spasms?
Muscle spasms are really too much muscle spindle and Golgi tendon activity. So in a nerve that actually has a deficit, you're not going to notice a spasm. You're going to notice spasms around an area that's overworking for an area that has a deficit. So it's very atypical for a muscle to have a spasm if they have neuropathy as a primary implication.
Okay, so a nerve can have a deficit, or can it have a hyperstimulation?
Hyperstimulate, like if a nerve has a deficit in proprioception, it's not going to spasm. It's not going to encourage spasm.
Okay.
Spasticity is like, cramping, for instance. That happens. The only thing they've been able to prove in research with a good amount of validity is that it's too much information. It's neurological aberrant information. It's like a short wire, like it's excessive neurological activity. So if a muscle spasms around an area, like a disc herniation, for instance, like if someone herniates a disc and their low back gives, right, that area is not supplied by the nerves that are actually impacted. It's usually areas above or below the site. And so the spasticity happens due to a non-impacted structure that's trying to pick up the slack for something with a deficit.
So spasms are protective
areas.
Tightness. What then a trigger point?
Oh God, trigger points. I'm not thoroughly convinced that they exist. So I worked in a pain management clinic, okay, and so he used really, really high grade diagnostic ultrasound, and he's a great pain management specialist. I loved working for him, and I asked him, I was like, I want to see a trigger point on ultrasound. I want to see what it is. And my thesis advisor also did research on trigger points, trying to find inflammatory cascades or whatever. There's nothing there. But there is a neurological activity that just can't be seen macroscopically. I think that, what's happening is that nerves are bloodthirsty. They're massively bloodthirsty. They have their own blood supply called vaso nervorum. And when they don't get the blood supply that they need due to traction, due to impediment of circulation, they start to develop a protective mechanism of tightness around their areas. And so that's neurological tension. And so when people say a trigger point, I get a trigger point injection. What they're getting is like lidocaine or dextrose injections, sometimes even Kenalog. I think Kenalog's a mistake, but they have that injected into a trigger point, right? And you're reducing the neurological activity of the area. I also think that's a big mistake to do that in most cases, because you are cutting down a neurological response that's attempting to protect you. So you got to be really careful doing that without matching it with rehabilitation. So if someone's getting trigger point therapy, they should immediately follow that with rehabilitative strategy so that they can get to the root cause of why the person has the trigger point in the first place.
Oh my God, you're opening up so many questions. So nerves are like vampires. Okay.
Blood vampires. They are. It's like watching that Twilight series, or any other vampire series that you might like. It's nerves. Remember, I'm obsessed with nerves. I'm obsessed with blood. Like in a profession that's obsessed with fascia, I kind of go, huh? Because I'm like, wait a minute, fascia is a real slave to blood, right? And not the other way around. And nerves are a real slave to blood, right? They have a very synergistic relationship. And nerves, if they are not getting their blood supply, they're going to be like, well, what the heck do you want me? You want me to conduct electricity? You want me to actually? No, I'm not going to do that. So you could experience these deficits neurologically rooted to blood issues. I mean, think about it. Think about Think about diseases like diabetes and hypertension. What are their primary symptomatologies? They have to do with neuropathy, right? Diabetic neuropathy. Diabetics have 3 to 5 times more back pain than non-diabetics, right? They definitely get more neuropathy, like 10 times more neuropathy than non-diabetic patients. Why do they have neuropathy? Because it's a blood steal. Diabetes wreaks havoc on blood vessels. And if you wreak havoc on blood vessels, then you promote neuropathy. That's why diabetics get neuropathy. So I'm obsessed with blood, looking at blood work, understanding the way the blood works, lymphatics, and of course neurology. I'm obsessed with nerves. Big nerd for nerves. And but when it comes to like trigger points, like I'm not gonna. I mean, like in acupuncture, we call it osher. Like we find it a trigger point, a painful spot on a patient, and we throw a needle in it, right, just to dissipate some of the nociception. But you don't just do that. You don't just treat osher points in acupuncture. You get to the root of the problem. Like we consider that treating a branch and then getting to the root of why the person has the tension in the first place. And that's why I'm proud to be a chiropractor and a rehab specialist, because I'm not just going to throw darts at people and then hope for the best, right? I'm not just going to encourage them to get injections. If they want to get injections and they find it to be helpful, I'm all aboard for that. But just the pain management specialist I used to work for, he would give them trigger point injections and they would immediately go into me for rehab, because you have to get to the root cause of the problem, or the trigger point is just going to keep coming back. It's going to keep coming back because it's trying to protect you and itself. Pain is not it's not this like your body's not punishing you with discomfort. It's trying to give you a signal to change.
Right on. So just to be clear to the listening audience, proprioception or loss of balance and your whereabouts in space is oftentimes a precursor to sciatic pain. I wanted to highlight
you would notice it in your feet.
Yes.
You would notice it in your feet first, probably.
And then as a follow-up, now what did you call the system that feeds blood to the nervous system? You referred to it as
vasonervorum is what they're called. Like that's the
nervorum.
Vaso means vessel, right? And nervorum means nerve. So vasonervorum is just like the particular little tiny blood vessels that actually go to the nerves themselves.
Beautiful. So now, with that said, all the different soft tissue therapies, trigger point myofascial pain, NIMO, spray and stretch, Graston, ART. Any merit to that, or
of course
that just one part? Why?
Because those are tools to try to encourage circulation, to try to move fluid, to try to really pump. It really comes down to all the techniques you name move circulation. And if we're a slave to circulation, which we are, right? And if somebody has impaired circulation, stasis, right? Inability to be able to move fluid, to be able to drain, waste products from tissues, then we suffer. So all of those techniques are wonderful. I'm certified in several of those to move, fluid. I mean, it really comes down to those things move fluid, those things move circulation. And then you rehabilitate movement. Motion is lotion, baby. You could, ART is an example of that, right? You're shortening, lengthening. Of course, that the body's going to respond by improving circulation and improving dynamics between spindles and Golgi tendons. Your entire neurological system is being improved. Your muscular system is getting the blood that it needs, and all of those techniques have beautiful merit.
So you also like cupping,
absolutely,
rolling cupping, dry needling,
sure,
as well as acupuncture.
Sure. I mean, I'm an acupuncturist. I don't do dry needling, but I see the merit in it. I don't think you should just needle stuff for the sake of needling stuff. I don't think you should just rub out stuff for the sake of rubbing out stuff. I certainly don't think you should cup yourself to look like Michael Phelps. I think you have to have a reason and a viable commodity to do it. And I also think that you have to ask yourself why these things are tight, why these things are circulation starved. Is there an imbalance between antagonists? Is there, rehabilitation in one's life as far as diet, exercise, movement therapy, all of that? You have to look very holistically at the patient to get to the roots and not just treat the branches all the time.
Gosh, I absolutely love that. So now, how do you feel about cryotherapy or ice after an injury?
I mean, the research has largely debunked a lot of cryotherapy is really promoting a healing of an injurious site. And so even the guy that coined RICE, rest, ice, compression, and elevation, said that rest and ice are, he was wrong. He went on record 10 years ago. He originally said that 30 years ago. And 10 years ago, he went on record saying, nope, I did the lit review and I was wrong. And then, no, everybody just keeps icing everything. Like you see it on sports teams, you see it in households, and ice is going to be mental trickery, okay? You're going to feel that cold instead of pain. So I don't have a problem with it for pain management. I totally get why people do it, right? But you better understand this, that ice also causes vasoconstriction, and you might want to have some vasoconstriction in an injurious site, but you don't want to have a prolonged vasoconstriction because you're going to delay the healing of the site of injury. So I tell my patients, if you want to ice within the first 48 hours, I totally get that. For pain management purposes, fine. But if you're using cryotherapy for chronic pain, you are missing the boat. It is not going to work really for healing a pattern that's promoting pain for you. It's not that it does massive harm, but I'll tell you what, in Chinese medicine, we have a whole book called the Shanhan Lun, which is the treaty on diseases caused by cold invasion. So it wouldn't be the first thing. I see all of these people like dumping themselves in tanks to try to control their norepinephrine. And I'm thinking to myself, have you seen the brain mapping of sensation? Your face, tongue, head, take up half of your brain mapping. All you got to do is put ice on your face. All you got to do is put cold on your face. And you'll get the benefits of vagal tone and something called the trigeminal cardiac reflex. So I can see you using like ice on your face, like an ice pack on your face. I can see using ice for pain management. It's just not something I'm like, hey, patient, does it help you? Great. Does it do any harm? Probably not. Okay, go ahead. But I'm certainly not going to be the first person dumping myself into a tank. It's not going to happen.
Terry, the audience is going to go wild.
Well, I mean, I will argue. Yeah, I will argue. Yeah. I mean, I know that people people love Huberman, and I saw him live, and he's a brilliant neuroscientist out of Stanford, and he is promoting people dump themselves in tanks. I'm thinking to myself, I don't really see the point. I think that you can put a freezer pack on your face, and then you don't have any kind of you'll still have the norepinephrine response. You'll still have the trigeminal cardiac reflex, the mammalian dive response. You'll have all of that. I don't think that you have to dump yourself into a cold tank. And in fact, in my Chinese medicine part of me says, please, half of you probably would cause injury with that. Like it's not the best idea. So I'm not going to put people in cryo tanks. I'm not going to encourage them to dip themselves in ice baths. I'm just going to tell them, if you really want to experience you can get the majority and benefit of that by putting it on your face. That's just basic anatomy.
Dr. Dooley, I absolutely love your renegade approach and fearlessness in driving yourself into the controversy. And I love that I love your opinion on this, and I'm quite congruent with the thought system, the belief system.
I'm just an annoying kid, Spencer. I'm like, I was the annoying 2-year-old. Like with my mom, I was like, why? So when people started dumping themselves in tanks, I was like, why are they doing that? And like, oh, they're trying to control norepinephrine. So they know that they're going to have a norepinephrine surge when they dump themselves in a tank. So they're trying to control their response whenever they have a norepinephrine surge, like with turbulence on a plane, if you're me, right? Well, dumping myself in a tank does not help me control that. But you know what it does? 5-10s. My husband taught me how to breathe to control norepinephrine. So I can use breathing and a cold mask on my face. And I don't have to put myself through the misery of dumping myself into a cold tank and feeling, my uterus occlude, for a lot of reasons. I just don't think that anybody needs to do that. I really think that is a fad that is going to fade, I hope. I hope, I always think that, the word fade is fad with evolution, right? So a lot of these things just pass and go. And I think that hopefully that will pass. But because you have this primary neuroscientist actually suggested that people are dumping themselves in tanks. And then, and I'm like, you really don't have to do polar swims. You don't have to buy yourself a cold tank. You can just put it on your face. Let me show you the somatotopic, the sensory homunculus of man. And let me show you that this right here, if you just splash your face with cold water, you don't even have to take a cold shower. You just have to put it on your face. That's 50% of your mapping. It's just over here.
Tell us how you really feel, Kat.
I mean,
No,
like
no,
I'm the one that has to treat the aftermath. You know what I mean? Like people come to me and they're like, "Oh, I did the cold tank and now I've got varicose veins, and I did the cold tank and now my knees are bothering me, and I did the cold tank and so I have to deal with all of those, and I'm like, I'm so happy you're trying to control your norepinephrine and stress, but you can do that without dumping yourself into a cold tank. I just don't believe in robbing Peter to pay Paul. Like you don't have to experience all these deficits in order to experience gains. You don't have to take 2 steps forward and 1 step back. You can just take 3 steps forward.
All right. So wait, I'm going to challenge you. You ready? I'm going to challenge you a little bit on this.
Yeah.
I get it that rest, ice compression, elevation, or price, pressure,
yeah.
that the idea of using ice in the first 72 hours, I would like to give ice a little bit of merit. And here's why. Mm-hmm. Because, when I first heard that ice was not a therapeutic approach anymore, as we thought it was for pain and swelling, I thought that when I first heard it was some physical therapist that put it on his blog, and I go, this guy's looking for attention. I get it that prolonged ice but wait, hold on, because I know that you're ready to vomit.
No, I haven't even heard what you said yet. Go ahead.
I know he's rambling.
I'm just agreeing.
But I know that University of Miami, where they have their spine paralysis center, there was a big shift to put spinal injury patients immediately on ice that they found was something that beneficial. And the reason why is because swelling will also damage adjacent healthy tissue in the area.
In the spine. That's true.
What about,
because you have, but also I said that, Spencer, I said within the first 48 hours, it's okay.
Yes, you did.
So it's after the 48 hours that I think it loses its medical merit.
Great. I just wanted to get that clear.
There's therapeutic uses for ice. I just don't think that you need to do it. I mean, when you have a serious spinal swelling, like a spinal cord injury is completely different than someone with an ankle sprain. If someone has an ankle sprain, I tell them not to ice it because I want the swelling to be there to protect them from actually moving it. That's why swelling happens. Your body's not failing you by creating a swollen situation. So like if you have like a grade 2 sprain, grade 1 sprain and it's swollen, leave it swollen. Try not to ice it too much because we actually want to create a swollen situation so you can protect it. But swelling around the spinal cord is completely different. If you have fluid building up around the spinal cord, you can cause paralysis because you're hitting the spinal cord with water, with fluid. So that makes more sense. You can't like take all situations and make it global for ice to be bad. But I will tell you that within the first 24 hours, using ice on an area is not going to slow down the healing process that significantly, and you will still swell, right? And you will get. My argument is that doing it past 48 hours actually might slow the healing process because we actually want the inflammatory cascade to come in there and do debridement.
I imagine you feel the same way about anti-inflammatories.
I feel probably even stronger about that. I think I would probably rather someone use ice than an NSAID. Not only because ice causes very little harm, assuming that the person's not getting freeze or like frostbite. They're taking good techniques not to not get burn. But the NSAIDs actually they're not shown to really cause much benefit, and they do cause a lot of harm. They cause harm they're ototoxic, they cause gastrointestinal inflammation, they're related to a variety of other pathologies. And so when people start to take them, they take them and they keep taking them. And so if they're managing their NSAIDs, I can certainly see the argument of using them, but I try to get them away from using them because of the deficits they can contribute to more chronic situations.
Fantastic. No, I love it. I'm so glad that you elaborated on all that because it's something that's so important to all of us.
Well, Spencer, the moral of the story is the acute situation is different than the chronic situation. The acute situation of the first 72 hours, the rules are completely different than after 72 hours. And you just have to educate the patient about that. Like the first 72 hours are different than the rest of the time.
Mm-hmm. Love it. So now, if we took away everybody's Theragun and foam roller, you have any suggestions for home care when somebody has sciatic or
I
has low
don't
back
have
injury?
problems with the foam roller. I want to make that clear. I just find that it's so interesting that people will they'll foam roll for like years on a site and not ask themselves why it's tight to begin with. They don't have a foam roller deficiency. I don't have a problem with the foam roller, especially if they're willing to do the corrective strategies. And some people, they're so committed to their foam roller, if taking it away from them would be like taking candy from a baby. I'm not going to do that. I'm going to have a screaming kid, right? So instead, I'm going to say, if you foam roll, can we also do this right afterwards so that we create a strategy of stabilization for whatever you just released? Because I think your releases, or your tightness, I'm sorry, is functional. Your tightness might be functional dysfunction. It's creating a strategy for you. So instead of just rolling it out, let's actually get to the root of the problem by following it with activities. Same thing for the Theragun, same thing for a lacrosse ball, same thing for a golf ball, same thing for an elbow, cupping, dry needling, Graston, ART, all of it. I just want to follow it by trying to stabilize whatever that thing was attempting to stabilize.
To be clear, corrective strategies. Are you referring to maybe exercise or stretching or what?
Yeah, like finding out what their deficit is. Why does the person have the parking brake on? Why are they rolling down a hill? Right? Why are they tight? Like, and that can be looking at antagonistic relationships with reciprocal inhibition. For the layman, that would be like, hey, my biceps is tight. Look at my triceps and see if my triceps is really the problem. Or look at adjacent structures. Like if someone has elbow pain, like golfer's elbow or tennis elbow, sometimes just treating that locally is not going to be enough, and they may have a shoulder dysfunction or a trunk rotational problem, and that's why their golf swing or their backhand in tennis is that has a deficit. So not just treating locally, but looking globally at where the underlying problems may arise. Why the area is in pain may not be the only part of the problem.
Actually, I love that. If corrective strategies is really a good term to use to either add certain activities like exercise or stretching, or remove the insulting activities that they do during the day, which could be just sleeping on your side.
Yes.
Or picking up something.
Yes.
Okay. Beautiful.
Correct. Yeah, I love how you said corrective strategy is not just addition; it's also subtraction. Like trying to get people to limit a harmful movement pattern, or like you said, a sleeping pattern, and getting the partners to switch sides of the bed, which is really, really fascinating sociological study. It's like I get some angry messages from spouses after that.
That won't happen in my house.
Sorry. Looking at what we habitually do and looking for not just addition, but also the subtraction of things that might be offending factors. I love that you said that.
This has been so great for not only practitioners of healthcare, but also the lay people. So this is great.
Good.
But now we're going to go into our rapid fire.
Okay. This failed miserably last time. It was partly my fault. So
no. It's always good.
Okay.
And
I'm ready.
Are you ready, Dr. Dooley?
I will not elaborate. I will answer quickly.
I dare you. That may be the hardest part for you.
It's already getting...
that may be the hardest part for her.
Okay.
I bet she has like superior answers, but they're this long.
No, I'm going to be a good girl. I'm going to be succinct.
I love her.
I do.
I promise. Here I go.
What?
All right.
Question number 1. What is it about kettlebells that you love so much?
Most tool with the most variety for ballistics and grinds and stabilization.
Ooh, did you say grind?
Yeah.
Grind?
Yeah, like a press, for instance, or a squat would be a grind. Yeah.
Oh, interesting. Cool.
See, I did it.
2. Yes, I'm impressed. Let's see if it continues. What is
You're 1 for 5.
Yeah, you're 1 for 5.
That might be it. That might be all I get.
What is your favorite winter activity that is a little on the crazy side?
Probably wood chopping. I'm obsessed.
Why?
Am I allowed to elaborate? Okay, you're giving me permission.
Go for it.
I love the sling patterns, the rotational patterns. I love it because I'm doing a lot of it. Obviously, I wouldn't have mentioned it. Did it this morning. I love the cardiovascular activity, the ballistic activity. It's extremely satisfying for anger management. It's it's also like, I don't know, like when I swing a kettlebell, I feel very productive. I do. I love swinging kettlebells. I love pushing, pulling kettlebells. But there's something about chopping a piece of wood and putting it on a stack and then using that to heat your house. There's something extremely validating and probably very primal about it. So yeah, I guess it's probably a little crazy ish because I could get a wood splitter
Oh,
and just
that's
do
great.
it. But no,
No.
my husband and I do it ourselves. Our neighbors think we're nuts.
I actually liked chopping wood when I was
I
a
did
kid.
too.
It was great.
Yeah.
And I wondered why I was so into it, but you're right.
Oh my God, it feels
Good
great.
exercise, and it lets out a lot of aggression.
It does.
too.
Yeah.
Oh my gosh. Okay. This might be a difficult question to ask. What is something you learned recently that just blew you away?
My husband started, my husband's brilliant. He studies a lot and he was educating me on lithium. Now, lithium carbonate's what's used typically in medications for bipolar and severe depression. And it's a terrible form, not highly absorbable, not unlike calcium carbonate, limestone being used for calcium supplementation. It's just not a good form. And so he was educating me about like microdosing lithium orotate for just balancing mood and helping with focus, much like people microdose, psychedelics and psilocybin. So I started doing that with my husband, and it really helped with my focus and mood and alertness and memory, and so that's been the newest addition to my learning process. I'm always learning things from my husband because he studies a lot about nutrition, and he started sending me articles on lithium orotate, and I've learning a lot about that.
That was a great answer because it's something I've never even heard about.
Sorry, that was long.
Fantastic.
So my short answer: lithium orotate.
You're right. I think that needed an explanation. That was
Okay.
great. All right, now I'm gonna skip around a little bit. I'm gonna ask you if you could have lunch with anyone, past or present, who would it be and why?
I'm probably going to assume my grandmother that comes to mind first. My maternal grandmother, like I was a kid that was like largely kind of ignored. It was just a situation, it's probably why I'm so outspoken now and why I feel the need to teach and treat patients and be listened to. But she treated me like she was the first person in my life that treated me like I could be heard. And so I probably would have lunch with her and, thank her a lot for being the first to listen to me before anybody else would. She was great. She's really funny and really smart. And yeah, I probably would have lunch with her.
Well,
Cool.
you may end up loving me like your grandmother because I have already set you up and planted the seed to lecture at the Professional Football Chiropractic Society and
nice.
pro sports, which Terry will end up being the MC there and may be introducing you.
MC/ref for what I inevitably say, put my foot in my mouth.
No. I support feet and mouth all the time because I'm the king of it.
Yes.
That's why I wear a beard that covers all the stretch marks.
It somehow like goes over like a fart in church when I,
Yep.
like say something that, and I don't mean to offend anyone. I just want to challenge people's beliefs. I just want them to think for themselves. And yeah, what I say may be challenging. You don't have to agree with me. I just want you to be challenged and to think about why you believe what you believe. That's all.
I actually have an additional question that I want to ask you because it's come up so often and so many times that this is probably not going to be a rapid fire question, but your thoughts on peptides.
Oh,
Peptides.
I have some patients that are using like BCP, was it 157 and AOD, and of course semaglutide is really popular and now prescription
For what?
For glucose management. People are using it. I think they call it Ozempic as the non-generic name.
Yes.
And so the peptides are on the rise. The research is still kind of brewing and building. So if you're evidence based, it's, we're going to need more data collection. But I'm certainly interested. It seems to be like the peptides don't cause as much harm as a lot of the other. They are synthetically derived. They're made in a lab. They're made in a compound pharmacy, right? So they're expensive and not readily available to a lot of people, with the exception of Ozempic. If you have obesity or some type of metabolic disorder, they're very happy to prescribe it. I guess my problem with the peptides is that some of my patients, they're not doing any kind of interjection of lifestyle management, and they're using peptides and asking the peptide to do a job. And the peptides, semaglutide actually does have problems. There is adversity associated with it, not only crippling nausea, but the pancreas. We need to do long-term studies on what it actually does to the pancreas, because it's controlling, insulin, glucagon, these chemicals. It's actually making your pancreas pump out more insulin, in ways. So it's, we have to do some long-term studies to see their benefit. But I certainly think that these peptides are interesting and they warrant our attention, because they may be the future of medicine, and they may cause a lot less harm than certainly a lot of the medications currently on the market do.
Hopefully it won't be a fad that will fade. I learned that from you.
Fads with evolution.
Right,
Fads with evolution.
Yeah.
I love that.
So I listen, we got to wrap it up, but I'm going to ask you one more thing. Yeah. But I feel like we could go on for another couple hours. Really. Terry, we may have to have part 3, but we'll discuss later. Since we last spoke, what is something that you wish you asked, or that you would like to get out there, that you feel everyone should learn or improve their health or their ability to heal others?
I think, I cannot, I just can't encourage people enough to do breathing training. It's something my husband, is really great at and has taught me to really go to. I have been doing this very consistently in my life. He's very consistent. I've watched him for 7 years be really consistent with it, never skip a session. And for me, he's taught me to do it in times of real duress. Like for me, turbulence is really one of my great fears. And I face my fear because I fly a lot. But facing your fear without a tool can be really challenging and really almost perceptually, damaging. So, I would tell people to get a very basic breathing practice and practice it in times when you're happy, times when you're sad, times when you're depressed, times when you're excited. Don't just let it be something you go to when you're stressed out. Train yourself to do it all the time so that you know what your normal state is. And then I think that people can do that along with whatever else they do, dumping themselves in tanks and meditating and whatever. There's a million different ways to stress manage, but I think one of the most imperative things that people can do for their health is have a very consistent breathing practice in situations, in all situations, and non-negotiable. Just every day, like teeth brushing. Maybe do it when you brush your teeth, so you'll always remember to do it.
I've become a lot more conscious of breathing through my nose, even just running on the beach this morning, and it's definitely fun to be aware of that.
Challenging. It's challenging.
Yeah.
And if you can control one of the
is.
most basic functions of your life that you do 25,000 times a day, if you can be in control of that, you can be in control of anything. And there's nothing that you can't face. And so I think it's just, if you can keep things more basic, you don't have to overcomplicate things. I'm happy to teach you how to swing a kettlebell with that awesome breathing. But you can also just start by breathing. And then applying that to every single aspect of your life and see how your life changes, and it will change.
Oh. This has been a super informative, highly energetic, and I get goosebumps every once in a while. I just don't raise my arm up every time to show you guys, but I love it. You are absolutely an asset to our profession,
thank you.
To any healthcare profession for that matter. I am
nice.
Definitely going to integrate you into every possible area where you can be heard.
That's so nice.
By all.
Thank you.
Thank
I don't mean
Kathy.
to be combative, folks, like that are listening. I just
I like it.
I just want you to challenge. Just always think and challenge that we are at there's one deficit that we have as a population right now, and it's our critical thinking. And it's really not promoted in a lot of educational situations. And actually, if you ask why, don't be afraid to hear the answers. Just challenge. You just ask why. If your cholesterol is high and your doctor wants to put you on a statin, ask why. Like, just, ask questions. And then there's nothing wrong with having some debate. I think it's really healthy to critically think. So hopefully this talk has helped you to critically think.
It's fantastic.
Awesome.
Thank you, Kathy.
And what Mavericks
again.
changed the world, so we appreciate you and everything you do.
Oh, thank you very much. Thank you both for what you do. I hope that you folks can keep doing these great talks.
Oh, love this. All right, Kathy, until next time.
Thank you for listening to today's episode of the Crackin Backs Podcast. We hope you enjoyed, and make sure you follow our Instagram at Crackin Backs Podcast. Catch new episodes every Monday. See you next time.